granulomatous lesions of skin. And to speak it authoritatively on the topic, we have a very special speaker with us today, who is both a dermatologist and a pathologist, with a vast experience of 32 years in the field. On behalf of the IAPM Kerala chapter, I am very much privileged and happy to welcome Dr. G. Nandakumar, my beloved teacher and mentor. Sir actually needs no introduction at all, but for the junior pathologist and the residents, a short introduction on sir. Nandakumar sir is actually now working as senior consultant dermatologist at Cosmopolitan Hospital and King's Health Trivandrum. Sir is also working as consultant dermatopathologist at the Doctor's Advanced Diagnostics Lab Trivandrum. Sir was the former HOD in pathology, Government Medical College Trivandrum, and retired as a principal from Trivandrum Medical College. There is a lot more to say about sir. Sir is a national coordinator of the IADVL SIG Dermatopathology for the years 2013-15 and 2021. And sir, I have also served as the Vice President of IADVL Kerala chapter for the years 2011 and 2019. And also as the President of Trivandrum Dermatology Club during 2017 and 2020. Sir is a member of the editorial board of 5 national journals and also has authored chapters in 3 textbooks with more than 35 publications to his credit. He has been the guest speaker for more than 200 conferences in national and international level. And a lot of awards have been received by sir. To mention a few, sir has received the Dr. L. Marquis Memorial Award for the Best Guest Lecturer in Dermacon IADVL 2016. Then Dr. Ganapati Panchar Memorial Award for Dermatopathology IADVL 2018. And sir has delivered speech on IADVL Kerala Oration 2022 and in West Bengal Cuticon 2021, Professor B.N. Banerjee Memorial Oration. And he has received the President's Appreciation Award during the IADVL Kerala 2019. And also got the Best Kerala Best Teacher Award in 2023, Professor Dr. M.J. Sirik Memorial Award, IADVL Award. Then sir has been the chairperson for the scientific committee in various conferences in the South Zone and also in Kerala. So I'm so much happy to welcome sir, my mentor, my teacher, and very close to me during my PG time. Welcome sir to the webinar.
Good evening all and welcome to this session. I congratulate IAPM Kerala for this wonderful initiative. I think first time that such a program or a series of lectures are conducted prior to an IAPM slide seminar. And I'm really happy to be part of this activity. And I thank Dr. Deepa for the words of introduction. We shall start sharing my slides. I hope my slides are visible full screen.
Yes, sir.
Okay.
Yes, sir.
Right. So the topic which we are going to deal with today is on granulomatous dermatosis. Those who are practicing dermatopathology or are reporting on skin biopsies would know that an average of 30 to 40% of daily skin biopsies would be of granulomatous dermatosis. So it is very important that we have a reasonable idea about this condition, which can have numerous clinical as well as pathological manifestations, as I would be attempting to demonstrate to you during the next 45 minutes or 50 minutes of my time. Dermatopathology, by definition, is a joint subspecialty of dermatology and pathology that focuses on the study of cutaneous diseases at a microscopic and molecular level. It is unique in the sense that such a joint subspecialty do not exist in any other branches of medicine. Both the pathologist as well as the dermatologist are dependent on each other in arriving at a useful diagnosis, which helps in the management of the patient. We know that the term granuloma originated from a misconception that these kind of lesions represented a neoplasm. And therefore, the prefix, the suffix oma was added to the name of this group of conditions. That is how the term granuloma came into being. And for a considerable period of time, there was confusion regarding the differentiation between granulomas and granulation tissue. But now we know that granuloma, by definition, represents an organized collection of mature cells belonging to the monocyte macrophage system. That is the definition of granuloma. And as we go forward, we realize that there are different types of granulomas, as we shall subsequently see. Apart from the hematoxylin and eosin stain, there are few histochemical stains which are very important in identifying or categorizing these granulomas. The Seal-Nielsen stain, Pfeiffer-Acho stain, Giemsa stain, reticulin stain, PAS stain, methenamine silver, Alshin blue, elastic Van Giesen. To this, one can definitely add Gram stain also. I left it out as an omission. Gram stain can also be added to this list of histochemical stains. So accessibility and availability of these histochemical stains is very important in our workup of a granulomatous dermatosis. Basically, we have the 6 types of granulomas that we encounter in our practice. Sarcoidal granuloma, tuberculoid granuloma, necrobiotic, suppurative granuloma, foreign body granuloma, xanthogranulomatous granulomas. One should realize that these categories are strictly not watertight compartments. There can be overlap in the histopathological findings between these different types of granulomas. That is, one can have features of both sarcoid and tuberculoid together. One can have features of tuberculoid and suppurative together. One can have features of suppurative and foreign body together. So we should keep our mind open in categorizing granulomas into these 6 categories. What is the expectation of a clinician when that person sends a biopsy of clinically suggestive of a granulomatous lesion? The foremost point that we should offer to him by way of diagnosis is whether it is an infection-associated granulomas and non-infectious associated granulomas. I don't have to elaborate on the importance of differentiating these 2 categories. Their management and prognosis is entirely different. Are there histopathological clues to infection-associated granulomas? We know that there is a granuloma in the biopsy. Are there any histopathological clues to tell us that it could be an infection-associated granuloma? Then only we can go forward with our further workup. There are certain epidermal changes like hyperkeratosis, parakeratosis, crusting, papillomatosis, acanthosis, which may be pseudoepitheliomatous hyperplasia, neutrophilic or eosinophilic abscesses. Then certain findings in the dermis, like the granuloma being a diffuse one, presence of a background inflammation, that is, the granuloma is located in a background sea of inflammatory cells, presence of necrosis, suppuration, presence of neutrophils, eosinophils, and macrophages in the dermis. These are few findings. I wouldn't say they are absolute, but these are findings which I have found useful in identifying the lesion as belonging to an infectious process. This skin biopsy showed hyperkeratosis, and one can identify parakeratosis also. Mild papillomatosis is seen, and there is definite epidermal hyperplasia by way of irregular acanthosis. And this view shows a dense cellular infiltrate in the upper dermis, which on closer examination shows that there is indeed a granuloma embedded in a sea of mononuclear cell infiltrate. And this granuloma shows multinucleate giant cells like Langerhans type of giant cells, good number of epithelioid cells also. So possibly this is a tuberculoid granuloma. And based upon the histological clues which I mentioned, this could be an infectious cause to the formation of this granuloma. And with CPC and the knowledge about cutaneous tuberculosis, this lesion could be cutaneous tuberculosis. And among the different types of cutaneous tuberculosis, tuberculosis verrucosa cutis is a lesion which shows this kind of epidermal changes plus the tuberculoid granuloma in the upper dermis. So the diagnosis of this condition would be cutaneous tuberculosis consistent with tuberculosis verrucosa cutis. The epidermal hyperplasia, as I mentioned, could be quite massive. It could be a pseudoepitheliomatous hyperplasia, might even show changes to squamous cell carcinoma. We have seen many conditions belonging to this group where the pseudoepitheliomatous hyperplasia has progressed into frank epitheliomatous hyperplasia. So the low-power view shows us this epidermal hyperplasia with, again, a diffuse kind of infiltrate in the upper and mid dermis. And even at this view, we can make out few multinucleate giant cells. Is this a tuberculoid granuloma? In contrast to the one which I showed in the previous slide, the granuloma here is not well formed. We are seeing scattered cells plus multinucleate giant cells. Let us go closer and look at the multinucleate giant cell. It shows these colored fungal bodies telling us that it is indeed chromoblastomycosis. Deep fungal infections of the skin, as they are conventionally known, to differentiate them from superficial fungal infections, which include the dermatophytic infection. Deep fungal infections are an important differential diagnosis, both clinically as well as pathology-wise, and careful screening of the sections is important sometimes to identify the fungal bodies in H&E sections itself. Where would we look for the fungal bodies? The fungal bodies can be present in the superficial layers of the epidermis, within the epidermis. Why? Because they are extruded through the epidermis by way of transepidermal elimination. They can also be seen within the giant cells, as in this case. And if there are abscesses, in fungal infections, one tends to see eosinophilic abscesses. They can be seen within the abscesses also. So this is chromoblastomycosis. And one should remember that in this scenario, there is no need, or it can even be counterproductive if we ask for a special stain for fungus, because a special stain for fungus would mask the inherent melanin pigmentation of these fungal spores. So once you see this kind of a structure, we can confidently sign off the report as chromoblastomycosis, deep fungal infection of the skin consistent with chromoblastomycosis. If in addition to the rounded bodies, we are seeing some hyphal structures also, the condition to keep in mind is phaeohyphomycosis, especially in these days when a lot of people are on immunosuppressive post-transplant, the incidence of phaeohyphomycosis is on the rise. And phaeohyphomycosis can be differentiated from chromoblastomycosis by light microscopy by the presence of hyphal structures, which are usually absent in case of chromoblastomycosis. This is a clinical scenario where the patient presents with non-healing ulcerative lesions which might have progressed to form sinuses. And the lesions tend to be localized to those anatomical sites where inherently they are rich in lymph nodes, lymph node associated anatomical sites. And the microscopy would show ulceration. This, of course, is an artifactual change. Ulceration. The epidermis, by way of reparative process, can show hyperplasia. But in contrast to tuberculosis verrucosa cutis, where we saw the granulomas in the upper dermis, here the inflammation is deep-seated, as you can see in this scanner view. The upper portion is relatively spared. The infiltrate is more towards the deeper portion of the epidermis, and we can make out some circumscription for the infiltrate. And on closer scrutiny, we identify them to be epithelioid cell granulomas. These epithelioid cell granulomas are seen in the background of abundant inflammatory cells, not only lymphocytes or plasma cells, but also intact as well as fragmented neutrophils. One may even encounter several foci of necrosis or suppuration. This is another type of cutaneous tuberculosis, scrofuloderma. Not as common as tuberculosis verrucosa cutis, but again, very important to diagnose. And it is also very important to receive an adequately deep biopsy so that we can see the deep-seated granulomatous inflammation. Sometimes the cutaneous granulomatous inflammation may lie in contiguity with the lymph node granulomatous inflammation also. This is the hyper view showing the Langhans type of giant cells, the epithelioid cells embedded in an abundant inflammatory cell infiltrate. So this is scrofuloderma. This is the reason why people mistook granulomatous inflammation as a neoplasm in the earlier stages. This elderly lady has a plaque lesion with areas showing atrophy on the face. It tends to heal in one area, whereas it tends to progress in the other margin. This is a young boy having a similar plaque lesion, which also tends to show areas of healing as well as progression. So it is a partly atrophic, partly hyperplastic lesion with areas of atrophy and healing. And what does the histopathology show? Histopathology shows, because the biopsy was taken from an atrophic area, it shows atrophic epidermis with keratotic plugging. And similar to what we saw in tuberculosis verrucosa cutis, we are seeing granulomatous inflammation in the upper and mid dermis, composed of large number of Langhans type of giant cells, epithelioid cells. Once again seen in the background of abundant lymphoplasmacytic infiltrate. This is the histopathology of another type of cutaneous tuberculosis, lupus vulgaris. The term lupus vulgaris refers to the clinical appearance of the lesion. Vulgaris is a term which means common. The translation of vulgaris means common condition. Lupus is the clinical appearance, as if a wolf has bitten the skin. That is the explanation for the name lupus vulgaris. So here also one should be very careful in signing off the report as cutaneous tuberculosis. We should screen the sections for foreign body reaction. We should screen the sections for presence of infective organisms like fungi or parasites. These lesions do not show any eosinophils per se, but tends to show neutrophilic abscesses like in tuberculosis verrucosa cutis. But in lupus vulgaris, it is comparatively rare. We find epidermal atrophy and hyperplasia with a diffuse kind of granuloma, classically tuberculoid granuloma in lupus vulgaris. So what have we been talking to till now? We were talking about epithelioid cell granulomas and cutaneous tuberculosis. Cutaneous tuberculosis can be of several types, as we just now saw. The primary tuberculosis tends to show extensive suppuration. It is comparatively rare. Whereas lupus vulgaris can show atrophy or hyperplasia. It tends to get ulcerated, as we saw in this patient. Can show necrosis. Tuberculosis verrucosa cutis usually do not get ulcerated, but instead shows hyperkeratosis, parakeratosis, papillomatosis, and neutrophilic microabscesses. And scrophaloderma is a deep-seated lesion with granulation tissue formation also. And it may, in contrast to the other types of cutaneous tuberculosis, may show some eosinophils also. These are few clinical conditions where we encounter tuberculoid granuloma in the biopsy. Cutaneous tuberculosis, as we have seen. Then the group of conditions which are a hypersensitivity reaction to a focus of tuberculosis, like tuberculitis. Leprosy, the paucibacillary type of leprosy. Late lesions of syphilis. Later lesions of leishmaniasis. Lupus miliaris disseminatus faciae, which was earlier considered to be a tuberculite, but now considered to be a different entity of unknown etiology. Rosacea, granulomatous rosacea, and cutaneous lesions of Crohn's disease. So these are the conditions where we encounter tuberculoid granuloma in the biopsy. Granulomatous lesions of the face is always a problem, and we should be very cautious in signing off or labeling the lesion as a clinico-pathological entity. This young person had these acneiform lesions, papular lesions with mild inflammatory signs of inflammation, few of which he had got excoriated, distributed over the central portion of the face, initially diagnosed and treated as simple acne, did not respond to treatment. Patient subsequently developed lesions on the earlobes also, and a biopsy was done. And biopsy showed upper dermal tuberculoid granuloma with large area of caseous necrosis. The granuloma tends to extend to the deep dermis, can engulf adnexal structures. This is the lupus miliaris disseminatus fasciae, or LMDF, where we find classical tuberculoid granuloma with caseous necrosis located in the upper dermis. It is imperative that the patient be worked up for tuberculosis before we label him to be having LMDF, which incidentally have got a different line of management compared to cutaneous tuberculosis. So which are the epithelioid cell granulomas that shows necrosis, or tuberculoid granulomas that shows necrosis? Lupus vulgaris can show necrosis. Scrophloderma, as we saw, can show necrosis. Lupus miliaris disseminatus fasciae, a totally unrelated condition, can also show extensive caseation necrosis. So caseation necrosis doesn't always mean that it is tuberculosis. And rarely we can see necrosis even in sarcoidosis, syphilitic lesions, or even fungal infections. Though one can argue that in fungal infections, it is mostly suppurative necrosis, and in sarcoidosis, it is fibrinoid necrosis. Talking about lesions or granulomatous conditions occurring on the face, I unfortunately do not have the clinical photograph of this particular patient. A middle-aged lady with erythematous rash on the central portion of the face. It used to exacerbate and subside depending upon her daily activities. Sunlight used to exacerbate it. Taking coffee or alcohol would exacerbate it. And finally, a biopsy was done, and it showed this kind of a patulous follicular orifice with dense infiltrate in the vicinity of the pilosebaceous unit. And going closer, we see that they are all tuberculoid granulomas. We can see good number of Langhans type of giant cells. So another condition presenting on the face with tuberculoid granuloma. This is the histopathology of granulomatous rosacea. There may be a few lesions where we cannot really label what clinical pathological lesion it is, even though it shows granulomas. Do not be tempted to diagnose leprosy on granulomatous lesions of the face without proper clinical pathological discussion. One can land in trouble. There may be conditions where we will have to just wait and watch. A group of entities which is labeled as figure, that is facial idiopathic granulomas with regressive evolution. It might subside by itself, leaving us with no clue what indeed the lesion was. So that is the importance of facial granulomas. A couple of decades back, these lesions were something which we used to read only in textbooks or was mentioned in publications from Western world. With change in lifestyle, larger number of patients who are immunosuppressed due to various reasons, we see many types of this condition. My patient was into the business of ornamental fish farming. So he used to put his hand inside the fish tank to take the fish and all. And subsequently, he developed this papillonodular lesions. The history was very, very suggestive. And we found a diffuse granulomatous inflammation. Unlike the compact tuberculoid granuloma that we see in most of the cutaneous tuberculosis, this showed a diffuse granulomatous inflammation. But large number of Langerhans giant cells were there. Presence of suppurative focus was there. You can see some neutrophils scattered here. Once again, with proper history taking and clinical discussion, one can suggest a possibility and excluding presence of fungal organisms by doing relevant histochemical stains. One can suggest possibility of atypical mycobacterial infections if this kind of a histopathological picture is seen. The management of these group of conditions is different from that of tuberculosis. We do not usually treat them with ATT. Once again, it is a diagnosis of exclusion. That is what I would say. But be alert to the possibility of atypical mycobacterial infections. They are comparatively more in number compared to a couple of decades back. One may encounter granulomas in totally unexpected scenarios. This was a patient, as you can see in the histopathology, with subepidermal blistering disease. It's a diagnosed case of bullous pemphigoid on treatment. He developed few crusted lesions on the shin area. So the clinician took a biopsy from an area away from the crusted lesion, hoping that the shin area would only show crusted exudate. And that showed bullous pemphigoid. The diagnosis was already there. So I asked him to take a biopsy from the crusted plaque on the shin area. We are a little hesitant to take biopsies from the shin area because it takes time to heal. And this crusted lesion showed a very large focus of suppuration, large circumscribed focus of suppuration. The overlying epidermis can be made out here. And it showed multinucleate giant cells, foreign body type of multinucleate giant cells with suppuration. So we were seeing a suppurative granulomatous lesion in this patient on treatment for bullous pemphigoid. And there were structures like this seen within the suppuration. We did special stain for fungus, the GMS, and it showed that there were indeed fungal structures. Not a very common species that we encounter in our practice. We submitted tissue sample for microbiological culture, which yielded Scedosporium species. There are several publications and reports of presence of deep fungal infections in patients with bullous pemphigoid. It could be a result of altered immunological response. It could be a result of perhaps immunosuppressives that the patient is taking. Anyway, this was a revelation that one should expect presence of granulomatous lesions in totally unrelated conditions also. What are the clinical features that may help us in narrowing down our differential diagnosis to infection-associated and non-infectious granulomatous dermatosis? Infection-associated lesions may present with hypopigmented or erythematous macules or plaques, verrucous lesions, ulcers, crusted lesions, tender and fluctuant nodules, polymorphous lesions. We tend to see lesions of different appearance, background of immunosuppressed state. On the other hand, the non-infectious granulomatous lesions can be asymptomatic. There is a catch in that word. We can get that in infection-associated ones also. But in non-infectious ones, they are mostly asymptomatic papules and plaques, patches or nodules. Annular lesions can be there. That can also occur in infection-associated condition. Tends to be of similar monomorphous presentation. If we find lesions symmetrically occurring on both sides of the body, of monomorphous appearance, in contrast to the polymorphous appearance, it could be a non-infectious granulomatous dermatosis. We come to a very, very important group of granulomatous dermatosis, which may have varied clinical presentation. It may be as inconspicuous as this hypopigmented maculopapular rash on the face. This is the site of biopsy, of course. This is the induration of the earlobe, followed by an erythematous patch on the face. It could be large geographic lesions, very large geographic lesions like this. It could be a single hypopigmented large patch. This is a plaque and this is a patch. And we saw non-descriptive hypopigmented lesion on the face of a young boy. All this can be seen in the posibacillary spectrum of leprosy. What are the challenges faced by the pathologist when attempting to report a posibacillary leprosy? Leprosy is identified by the presence of neurovascular granulomas. The difficulty in identifying fragmented nerve twigs on hematoxylin and eosin stained sections is an important hitch. In multibacillary leprosy, we see acid-fast bacilli in plenty, whereas in posibacillary leprosy, we do not see acid-fast bacilli. So that doesn't help us. And we are required to differentiate the posibacillary leprosy lesions from non-leprosy granulomatous dermatosis, which are dime a dozen. The crucial histopathological point is in identifying a nerve twig in the dermis. In the scanner view, in the lobar view, if we find the nerve twig staring at you or the nerve twig appears proliferated, one should suspect it to be leprosy and carefully screen the slides. See, this is the scanner view. You can see this vague infiltrate, but very localized, unlike the tuberculosis which we saw. This is the higher power view, which tells us that it is engulfing, the infiltrate is engulfing something. This oblong shape should alert us to the possibility of it being a neural granuloma. This curvilinear shape of the granuloma, appreciated best at the scanner view. So this is the leprosy pattern, the curvilinear shape of the granuloma, indicating that they are involving the neurovascular bundles. This is the higher power view of a neurovascular granuloma. You can see the tuberculoid granuloma at the center with large number of lymphocytes at the periphery. So the classical tuberculoid granuloma involving a nerve fiber. One would also see these bag-like infiltrates with granulomas at the center. This is actually a granuloma surrounding and involving the adnexal structures. So adnexal granulomas. These two findings point towards paucibacillary leprosy. So a tuberculoid granuloma, which is with the neurovascular and adnexal localization. Sometimes we are taken by surprise. This biopsy was from the elbow lesion, which one section of which showed an upper dermal band-like infiltrate. I was wondering whether I was dealing with a lichenoid dermatitis. Another section, fortunately, showed me the deeper portion of the dermis also, which showed the classical curvilinear granulomas, tuberculoid granulomas. This was a case of tuberculoid leprosy. Not borderline tuberculoid leprosy, but frank tuberculoid leprosy, where we can see the granulomas abutting or even eroding the overlying epidermis. Another clinical condition which causes considerable problem in diagnosis with its varied clinical presentation and sometimes very difficult histopathological findings, overlapping histopathological findings. Multitude of papilla lesions, asymptomatic on the face. And this is the discrete epithelioid cell predominant granulomas of sarcoidosis. Each word is important. Sarcoidal granulomas tends to maintain their individuality. They do not coalesce together as that of a tuberculoid granuloma. They tend to remain discrete. We can see the discrete nature of each granulomas, each of the granulomas. And they are predominantly epithelioid cells with multinucleate giant cells. The granulomas are so rich in epithelioid cells with its overlapping or interdigitating the cytoplasmic margins. They may give an erroneous impression of necrosis to a beginner in pathology. This is not necrosis, but this is only a naked granuloma, which is composed almost entirely of epithelioid cells. Questions are asked whether the type of giant cells would help us to differentiate between tuberculosis and sarcoidosis. The answer is no. In sarcoidosis, one can see both Langerhans type of giant cells as well as foreign body type of giant cells. Whether the inclusion structures like the asteroid body seen here or the Schumann body points towards sarcoidosis. Perhaps they are more common in sarcoidosis. That would be my answer. But it is not seen in sarcoidosis alone. It can be seen in any type of granulomatous dermatosis. Similarly, does reticulin stain help us in differentiating sarcoidosis from other types of granulomas? Answer would be perhaps. Large studies have been conducted which have shown that they are not really conclusive. Reticulin stain or the presence of intact reticulin fibers within the granulomas doesn't always tell us that it is sarcoidosis. Perhaps this is an adjuvant investigation along with other workup for sarcoidosis, which may help us to say, yes, this could be sarcoidosis, but we cannot say that this is sarcoidosis based on reticulin stain alone. We talked about presence of neurovascular granulomas important in the diagnosis of leprosy. But sometimes, the histopathology doesn't follow the textbooks. It doesn't follow Lever's histopathology always. Exceptions come. This was a patient who presented with large hypopigmented patch with absolutely no sensory impairment. And this was a biopsy. And the deep dermis showed these linear granulomas, the neurovascular granulomas. I thought that, yes, that could be the leprosy pattern. Surprisingly, going closer, it showed that the granulomas were naked granulomas with large multinucleate giant cell, foreign body type of multinucleate giant cell. We can see foreign body type of multinucleate giant cells in borderline tuberculoid leprosy, but here there were too large, and they were strictly naked granulomas. And I saw the patient myself. There was no sensory impairment. There were no thickened or tender nerves. So a diagnosis of leprosy was out. This was the hypopigmented type of sarcoidosis. And the hypopigmented type of sarcoidosis, to add insult to injury, can show this neurovascular granuloma. So once again, a careful examination of the patient and proper clinical pathological discussion would save us from an embarrassment later on. Foreign body granulomatous lesions sometimes are very easy to diagnose, as in this case. The foreign body stares at you. This was a vegetable material seen within the multinucleate giant cells. Sometimes they are seen in a background of intense suppuration or even presence of eosinophils. We will have to exclude, if the foreign body is not that visible, we will have to exclude the fungal infections. And polarizing microscopy is a very important test that you can do to identify these subtle foreign bodies, the suture material, for example. Presence of eosinophils points towards an infectious etiology, as we said. It could be a fungus, it could be a foreign body. So use histochemical stains and use polarizing microscopy when the histochemical stains are not really contributory in identifying a foreign body granulomatous lesion. This young boy presented to us because his classmates were making fun of him because his lower lip was gradually increasing in thickness. It was getting swollen. He was prepared for any investigative process. We did a biopsy of the lip. And this is the lip biopsy with rich, large number of sebaceous glands and an infiltrate in the upper dermis. And this was what we saw in the high power. A loose aggregate of epithelioid cells with Langerhans type of multinucleate giant cells. So this was a granulomatous inflammation, not very compact. Seen in the background of lymphoplasmacytic infiltrate. There was no necrosis. The clinical picture was very suggestive. This is granulomatous cheilitis. Granulomatous cheilitis. There are people who consider granulomatous cheilitis to be a type of sarcoidosis. Patient needs to be worked up for presence of sarcoidosis naturally. And this responds eminently to treatment. Annular lesions. We talked about annular lesions. This is annular lesion. Large coalescent annular lesions forming plaques. And what do we see here? We see upper dermal collagenolysis, now referred to as necrobiosis. There is a difference between necrobiosis and collagenolysis. There is no necrosis taking place here. So it is better that we use the term collagenolysis to refer to these group of conditions. We are seeing foci of collagenolysis. Even at this power, one can see the nuclei of cells at the periphery, typically mentioned as palisading arrangement, the parallel arrangement of the nuclei at the periphery, large number of epithelioid cells at the periphery of the central nidus of collagenolysis. A very useful histochemical stain for this, to diagnose this condition is Alshin blue, which shows positivity for mucin. And this is granuloma annularum. Broadly, the collagenolytic granulomas are categorized into red granulomas and blue granulomas. Blue are the ones which shows mucin positivity. And red are the ones which are negative and instead shows fibrinous material. That is granuloma annularum. In contrast to granuloma annularum, this patient presented with atrophic plaques on the shin area. And we are seeing parallelly oriented infiltrate with central nidus of collagenolysis. This is the closer view, which shows the central nidus of collagenolysis, multinucleate giant cells, larger number of lymphoplasmacytic infiltrate, few neutrophils. And one would also be helped if there is presence of foci of neutrophilic vasculitis. This is necrobiosis lipoidica. These lesions are negative for Alshin blue. Still deeper, the deep reticular dermis or involving the subcutaneous tissue, another type of red type of collagenolytic granuloma with this palisading arrangement of histiocytes and epithelioid cells, negative for Alshin blue. This is rheumatoid nodule. One would need to differentiate rheumatoid nodule from the subcutaneous or deep-seated type of granuloma annularum. This can be achieved by doing a mucin stain. The collagenolytic granulomas, I would consider them to be the glamour babies of the otherwise very drab, the granulomatous dermatosis with their sinister prognosis and diagnosis. But some of these collagenolytic granulomas do have very important clinical implications. Of course, an extensive granuloma annularum needs to be worked up for underlying conditions. This is another such entity, palisaded neutrophilic and granulomatous dermatosis. the collagenolysis will not be that evident, but instead we see a central foci of suppuration, palisade of histiocytes at the periphery. This patients usually have underlying systemic illness. It can be an inflammatory pathology like gastrointestinal conditions like ulcerative colitis, or it can be more serious conditions like hematological or solid organ malignancies. So that is the importance of identifying palisaded neutrophilic and granulomatous dermatitis, previously referred to as interstitial granulomatous dermatitis. Still at the topic of granuloma annulare, I forgot to mention that there are several histological patterns of granuloma annulare. The one which I showed is the easiest one to diagnose. It can also show this interstitial pattern where the collagenolysis is very subtle or limited. It can also present with sometimes with classical sarcoidal granuloma, where your knowledge as a pathologist will be tested to differentiate between sarcoidosis and granuloma annulare. So that is about granuloma. I think this is my last case. We started at 7:35, so I'm expected to finish at 8:35. This young gentleman had these kind of lesions on the head and neck region. Very unfortunate, asymptomatic for him, but very, very distressing all the same. And multiple biopsies showed a granulomatous inflammation, multinucleate giant cells, foreign body type of multinucleate giant cells. This is one focus. Another area showed multinucleate giant cells with foamy cytoplasm. Another one showed large areas of foamy cells, foam cells, entrapped blood vessels, interspersed by mononuclear cells. We did immunohistochemistry in the sections. The cells were vimentin positive and LCA positive. And taking into account the clinical presentation, the presence of bizarre multinucleate giant cells, foam cells, we arrived at the final diagnosis of multicentric reticulohistiocytosis. These lesions can be skin localized. If they are skin localized, the prognosis is good. Patient respond well to treatment. But sometimes they can have systemic involvement also. Sometimes it may be a totally unrelated hematological malignancies also, where the prognosis is, of course, guarded. So that was the last type of granulomatous dermatosis which I wanted to mention about. How do I approach the possible granulomatous lesion? Convince myself about its presence. That is the most important point. The granulomas always doesn't stand up and tell you that I am here. We will have to find out the granuloma. We will have to convince ourselves that there is a granuloma. Sometimes even a capillary with plump endothelial cells occluding the lumen can resemble a granuloma. So that is the first point. Is there an associated reaction pattern? Is there an associated vasculitis? Is there an associated lichenoid reaction pattern? Am I able to categorize the granuloma? I showed you almost classical types of granulomas. But in practice, we encounter many situations where there are overlapping features. We may not always be able to categorize the granuloma. Am I able to categorize the granuloma as tuberculoid, sarcoid, or suppurative, whatever it is? Correlate with findings in the epidermis and the dermis. gather as much information as possible. See the patient. I do this as far as possible. Examine the patient ourselves. The next best is seeing photographs, but they are not as good as seeing the patient. And when we look at the slide, visualize the patient as a whole. Otherwise, we will miss the diagnosis. We will miss the diagnosis. Avoid tunnel vision. Do not be inflexible. We are all liable to commit mistakes. Accept our mistakes, learn from our mistakes. And that is how we progress in this field. Utilize available ancillary investigations like histochemical stains, polarizing microscopy, IHC where it is required or where it is relevant. Reporting of skin biopsies is difficult because of the large multitude of inflammatory dermatosis. We have to supplement our theoretical knowledge with seeing slides, hundreds of them, to learn to have our foot in this subject of dermatopathology. And lastly, never be in a hurry to sign off a report. One can sleep over a skin biopsy. It is not urgent to sign off a report of granulomatous lesion today. One can do that tomorrow. But don't waste your time. We may come across newer ideas or newer findings if we look at the slide tomorrow once again. And then it may help the clinician and the patient in the long run. Thank you very much.
Thank you, sir, for the clear, crisp, concise talk on granulomatous approach to granulomatous lesions of skin. And we have a few questions.
I'm happy that I was able to finish in time. 8:36. Yes, good.
So there's a question from Dr. Rinku Susan. How do you proceed with a granulomatous lesion with clinical suspicion of atypical mycobacterial infection?
Yeah, I think I mentioned that, it is a clinical suspicion, first of all, atypical mycobacterial infection. And the diagnosis of atypical mycobacterial infection in most of our centers is a diagnosis of exclusion. We have to exclude it as a tuberculoid granuloma, it as a sarcoidal granuloma, do all relevant histochemical stains, do AFP stain. Now, there are PCR tests available even in our state, helpful in the diagnosis of atypical mycobacterial infections. There are two schools of thought with regards to this. One school says that they are confirmatory, and the other school says that they are only 50% conclusive. So that is how we arrive at a final diagnosis of possible atypical mycobacterial infection. Unfortunately, microbiological culture may not really contribute to the diagnosis in this scenario.
So there's another question. How would you diagnose BB leprosy histologically? The microscopy shown as TT in the presentation looked like a BT lesion.
Can you please repeat the question?
So how do you diagnose BB leprosy histologically? The microscopy shown as TT in the presentation looked like a BT lesion.
Hansen's disease patient will have lesions belonging to different spectrum. It is not a static disease. It is a dynamic process. With change in the immunological status of the patient, the histopathology of the lesions will change. Perhaps the biopsy taken would be that of mid-borderline leprosy. That means the patient is actually downgrading because of the immunodeficiency. How do we histopathology-wise differentiate mid-borderline from borderline tuberculoid leprosy? I understand that is what you want to know. In mid-borderline leprosy, there are no tuberculoid granulomas. there may be a smattering of epithelioid cells along with lymphocytes, and in mid-borderline leprosy, we have a higher chance of identifying acid-fast bacilli. So there is no compact neurovascular tuberculoid granulomas in mid-borderline leprosy. It is more of a loose kind of granulomas with epithelioid cells. Giant cells may not be seen. Langhans giant cells are not seen. One may see one or two foreign body type of giant cell, very rarely. But it's usually a scattering of epithelioid cells, and AFB tends to be positive.
So, any distinguishing histopathology feature of xanthogranuloma from reticulohistiocytosis?
It is more, it has to be a clinical pathological thing, you know. It has to be clinical pathological. We can utilize the immunohistochemical markers for doing it. Xanthomas have got, of course, a distinctive clinical appearance, and they will not show this much of giant cell reaction in one area, worm cells in another area, and the clinical picture entirely is different. And the IHC will help us.
Yes, Dr. Aruparna Sengupta, she has raised hands. Namrata, could you please unmute her?
Yeah, we have already allowed her to talk. Yeah.
Yes, thank you so much. Sir, my question is that recently I had a case. The clinician had a very strong suspicion as clinically of sarcoidosis, but the biopsy showed necrotizing granulomas, and it was not the reticle. It was not a reticulin-rich framework. I had done reticulin stain also, and gene expert as well as ZN stain were negative. So my query is that as per literature, literature says that sarcoidal granulomas may also show necrosis at times, large sarcoidal granulomas. So is there microscopically, is there any pointer to favor sarcoidosis over tuberculosis when the clinical suspicion is quite strong and favors sarcoid? Is there any such pointer?
Where the granuloma, naked granuloma? Where the naked granulomas?
There was a lot of inflammation around the granulomas.
So it is unlikely to be sarcoid. Unlikely to be sarcoid.
Okay. Okay, sir.
It has to be something else. Sarcoidal granuloma can rarely show tuberculoid features. That was what I was trying to impress upon. It can have overlapping features sometimes.
Yes.
But if we are not seeing an epithelioid predominant granulomas, they are diffuse granulomas, as I understand from your case.
Yes, yes.
And it shows necrosis. It is unlikely to be sarcoidosis.
Okay, okay, sir. Okay, thank you, sir.
Can we go to the next question? Any characteristic or associated finding in case of LMDF? Sir, I didn't understand what is LMDF.
That is lupus miliaris disseminatus faciae.
Any characteristic or associated finding?
Characteristic finding histopathology wise, I would say it shows upper dermal caseating granulomatous lesion, typically tuberculoid type. LMDF, the diagnosis is made on clinical pathological discussion and by exclusion of cutaneous tuberculosis. All the patient whom we diagnose as LMDF would be worked up to rule out tuberculosis. So it is a diagnosis of exclusion. We cannot be stubborn and say that this is LMDF, this is LMDF. The clinical presentation has to be suggestive. That is what I was talking about, granulomas occurring on the face. No, you need a clinical pathological discussion. We need the background. I mean, the rest of the investigations to be done before labeling something as LMDF.
That's a question: how to diagnose type 1 and 2 reactions of leprosy?
How to differentiate between the two?
Type 1 and 2 reactions.
1 and 2, right. We didn't go to the topic of reactions at all because my lecture was on granulomatous dermatosis. Type 2 reaction will show presence of vasculitis, leukocytoclastic vasculitis. That is one situation in leprosy where we find neutrophils in histopathology. Remember that. So when we find neutrophils in a lesion of multibacillary leprosy, suspect that we are dealing with type 2 leprosy. I mean type 2 reaction, I'm sorry. Type 2 reaction. Presence of vasculitis, presence of large number of fragmented acid-fast bacilli, sometimes lipid vacuoles, presence of neutrophils tells you that is type 2 reaction. Whereas in type 1 reaction, type 1 reaction can be upgrading or downgrading, as you know, depending upon the immunological status of the patient. We need to compare the original biopsy with the present biopsy to tell whether it is an upgrading reaction or a downgrading reaction. Type 1 reaction will have characteristic clinical findings by way of tender nerves and all. So the clinician will tell you that it is likely to be type 1 reaction. And on histopathology, if we compare the original biopsy with the present biopsy, if there is an increase in the number of lymphocytes, increase in the number of Langerhans type of giant cells, it is upgrading reaction. Whereas if there is a reduction in number of lymphocytes, AFB has become positive, it is a downgrading type of type 1 reaction. I hope I have made myself clear.
Thank you, sir. Is there any more questions? Namrata?
No, ma'am. There are no more questions. Only one question was there from Dr. Aparna was in the chat box. I think that is covered.
Yes, I have asked it. Thank you.
Thank you so much, doctor.
Sir, is there any role of elastic vancomycin in necrobiotic granulomas? Differentiating necrobiotic.
Oh yes, we can do that. We can do that. There are, I mean, some types of this collagenolytic granulomas which shows the giant cell engulfing fragmented elastic fibers. So there is a definite role for elastic vancomycin in that category of granulomatous dermatosis. Apart from algin blue, of course.
Okay, sir. So if there are no more questions, can we conclude?
We can, yes.
Okay, sir. So once again, sir, thank you for the wonderful presentation correlating both clinical and microscopy of each condition and also sharing your experiences. So on behalf of the IAPM Kerala chapter, I take the opportunity to thank Nandakumar sir for the excellent talk. And I'm sure that is a great loss for the young pathologists who have missed the session. And sir was my teacher and my PG guide, and fondly remember with deep gratitude how sir used to teach us dermatopathology, especially during the CPCs, repeatedly showing the findings and emphasizing how to describe the lesions and write descriptions and instilling the interest in skin biopsies. So I really feel fortunate to attend your class again after many years. And we also thank all our dear members for your active participation today. And we also thank Mindray India team for providing the platform and giving assistance for the smooth conduct and of the webinar series.
Dr. Deepa?
Yeah.
Ma'am, if sir has the time, we have one more question in the chat box. Can we take that?
Oh, yes.
Sir, I'll read a question for you. How to histological differentiate between new lesion versus partially treated lesion in leprosy?
I mean, it depends whether we are dealing with the possibacillary spectrum or multibacillary spectrum. In multibacillary spectrum, it is comparatively easier. In newly diagnosed lesions, we will find intact acid-fast bacilli. Whereas in partially treated lesions of multibacillary leprosy, there will be fragmented acid-fast bacilli, large lipid vacuoles, which are formed by this the degenerated cell wall of the acid-fast bacilli. So that part is easier. Coming to the possibacillary spectrum, it is difficult because many a time the clinician would want us to tell whether the treatment is completed and we can stop treatment. That doesn't really, the biopsy taken at that stage doesn't really help. But the density, again, we have to compare the biopsy with the original one. The density of lymphocytic infiltrate decreases as the treatment goes on. The density of the infiltrate decreases, but the granulomas may remain for as long as 2 years. That is what I understand. Epithelioid cells can remain for as long as 2 years. Presence of fibrosis, dermal fibrosis, tells us that it is a partially treated possibacillary leprosy. These are few points which help us in to differentiate a fresh lesion or a new lesion of possibacillary leprosy from a partially treated possibacillary leprosy. It is difficult, but these are few points. Presence of dermal fibrosis, reduced number of lymphocytes, the granulomas tends to show only epithelioid cells. These are some of the findings which can help us or guide us.